Today, our first Thursday speaker is Dr. Sam Metz. Dr. Metz is Vice President of Oregon's chapter of Physicians for a National Health Program and a founding member of his Mad as Hell Doctors. He was a member of Oregon's 2018 Universal Access to Healthcare Legislative Work Group and Oregon's 2019 through 2022 Senate Bill 770 Universal Healthcare Task Force. Dr. Metz is an adjunct associate professor of anesthesiology and perioperative medicine at Oregon Health and Science University. His opinion pieces have been published in the New York Times and many Oregon newspapers, including the Bend Bulletin. He has been a panelist on the NPR program To the Point, Lars Larson Show, and Tom Hartman Show, as well as local and radio and television programs. Please welcome Dr. Sam Metz.
Thank you very much. I greatly appreciate this invitation from the League. As you know, healthcare reform is the second leading cause of bar fights in America today. Number one, of course, is women, except in Portland, where it's fluoridation. What makes this topic so controversial is its complexity. This is the largest industry in the United States. It's the largest industry in the world. If the Saudi Arabians devoted their entire gross revenue from all the petroleum they sell, they could not pay for 1/3 of what Americans spend on healthcare. Healthcare does not obey the traditional laws of economics. As the cost of healthcare go up, the need for healthcare doesn't change. And finally, it's destroying families and businesses. Very few of our families could survive financially a major hospitalization. We are the only industrialized nation where you could lose your home paying for treatment for a treatable disease. The only country. Healthcare benefits are the leading cause of labor management disputes in the United States. That doesn't happen in any other country because no other country expects its employers to pick our insurance, our benefits, and our providers. What I hope to do in this discussion is give you enough information that you can think creatively about healthcare policies that you see. And if we're really lucky, I can get us the 12 steps it takes to understand what single payer means and what Oregon can do. This will be in the form of a few rhetorical questions. And the first one is, why do we need healthcare reform at all? You don't have to raise your hand, but just ask yourself, would I agree with this statement? It may have its flaws, but the American healthcare system is the best in the world. For those of you who are considering saying yes, don't feel alone. There were dozens of legislators, congresspeople, governors who in the past 10 years have said that. It's becoming harder and harder to defend that statement. Here's why. Americans pay twice as much for health care as the average in other industrialized countries. We are the most expensive healthcare system on the planet, probably in the galaxy, because no other intelligent life form would create a healthcare system like we have. If we were paying twice as much as other countries and we were twice as healthy, that would be acceptable, but we're not. If we were paying twice as much and we're just as healthy, it might be tolerable, but it's not. On most measures of public health and medical outcomes for any major condition, the United States is at or near the bottom of the industrialized world. We're talking about deaths avoidable with prompt treatment. Example, diabetics in the United States are twice as likely to suffer a foot amputation because their foot ulcer became necrotic than diabetics in Europe. And this is simply a matter of access to care. We have, as you know, as you just heard, some of the worst outcomes in the world. What are we trying to achieve with healthcare reform? Now, that's not an obvious question. This is where the bar fights begin. What we're trying to achieve is to get the government out of healthcare. No, we're trying to put the government into healthcare. No, we're trying to get the profit out of healthcare. No, we're trying to get the profit into healthcare. It's a social responsibility. No, it's a personal obligation. No, it's about social justice. No, it's about economic equality. Let's just take a deep breath and put on our caps that say head of family. As a head of family, what does our really good healthcare system, what would that look like? Well, first, there'd be access for our family. I'd want to know that no matter how hired, fired, retired, or expired I became, my family would get the healthcare they need when they need it, regardless of their credit rating. That's access. Second, I want my healthcare costs to go down. Making my taxes go down, but my premiums go up, or my premiums go down and my out-of-pocket payments go up, or my out-of-pocket payments go down and my price and my taxes go up, is an expensive game of whack-a-mole. It's all my money, and that sum total has to go down, no matter what the label is. That's lower cost. And lastly, I want better healthcare. I don't want to have to tell a pregnant member of my family that there are 59 other nations where she and her baby have a better chance of surviving the pregnancy. Access, cost, quality, or here's the bumper sticker version, better care to more people for less money. If you remember that phrase, better care to more people for less money, you don't have to pay attention to anything else that I'm going to say today. That combination has been called the iron triangle because it's easy to get any two of those if you sacrifice the third. You want better care to more people, pay more money. You want more people, but pay less money, provide bad care. Or you want better outcomes, better quality for less money, exclude sick people. And indeed, if you look at all of the proposals in the United States, you'll find that almost all of them sacrifice one of those goals for the other two. It's very difficult to get all three simultaneously, and that's what we want. How do we get to this better healthcare system? When we talk about public policy, as you all are well aware, there are three generic options. We can either keep doing what we're doing and hope for a better result. There's a medical diagnosis for that condition. Unfortunately, the Affordable Care Act is an example. It changed the rules, but we still have a zero-sum game. In the United States, the only way one person can get more care for less money is for someone else to get less care for more money. The second option is to try things that have never been proven to work in healthcare. Block grants, high-risk insurance pools, value-based payment. All of these are good ideas. The operative word being ideas. We don't know if they're going to work in healthcare. It's an experiment. The last option when we think about public policy is to look at systems that already succeed in providing better care to more people for less money and learn from them. Well, that process, that option is easy, then it's hard, then it's easy. It's easy because every other industrialized nation provides better care to more people for less money than we do. Any place you can drink the water, you can look at their healthcare system and they're doing better than we are. It's then hard because every other nation is unique. They all are different. Don't believe what you hear on talk radio. It's not all socialized medicine out there. Every nation has its own complexity, its own compromises with politicians, and it gets very fuzzy. But then it gets easy again. What every other industrialized nation has that we don't is universal healthcare. Now, universal healthcare is not just a left-wing slogan sprayed on the side of a dumpster. It actually has three critical components, all of which are lacking in the United States. Universal care programs first mandate that everyone participate in a prepaid healthcare plan. Prepaid means everyone pays before they get sick and pays nothing when they do get sick. Mandated means you don't have an option. You can't say, I'm healthy, my family's healthy, I'm not paying in until the day before my kid falls out of a tree, or the day before my house gets cancer. The second characteristic is every healthcare policy in the country, private or public, covers the same set of comprehensive benefits. Comprehensive does not mean unlimited. It means treatable conditions get a treatment. If you've got more money and you can buy more benefits, you are welcome to do so. But you can't withhold your money and get fewer benefits. That comprehensive benefits is a floor, not a ceiling. And lastly, any patient can see any provider, and provider payment reflects the value of the service, not the insurance. In insurance speak, these characteristics are one risk pool, that is human beings, one set of basic floor benefits, treatable conditions get a treatment, and one network, all providers. As I mentioned, every country has compromised some of that for political expediency, but we're the only nation that has none of them. So, what are the varieties of universal care? Here would be a good point to talk about the pipeline. Think about the American healthcare system pipeline. There's money pouring in one end and money going out the other. In the US, it's getting close to $4.5 trillion. When we talk about how do we get money into the system, who participates, how do we collect, who pays, that's called financing. When we talk about how the money comes out the other end, which providers are paid how much, under what conditions, for what patients, that's called the delivery end. There are two big phyla, as it were, of financing healthcare. One is universal healthcare, and the other is chaos. The United States is the only industrialized nation that uses chaos. Universal care, there's two ways to do that. One is everyone is mandated to buy an insurance policy, and the insurance policy pays the money into the system. That's a multi-payer system. The other variety is a single payer system. Everyone pays taxes to a government agency, and that single agency is responsible for paying everyone's health care. Just so you know, no nation is purely one or the other, but they're predominantly one or the other. The US, again, is chaos. So you have some vague idea of single payer. Now, there's a question that's going to come up, which is single payer provides better care to more people for less money. I'm sorry, that doesn't compute. The number you have reached is not a working number. How does it do that? Every billable act in the United States needs to be evaluated by a non-clinical administrator to determine if the patient was in the network, if the patient was covered at the time of service, if the condition was covered, if the treatment was covered, if the provider followed pre-authorization, and if the provider was in the network at the time the service was provided. All of that is repeated 30% of the time, because in the US, private insurance rejects 30% of all first claims. There are over 4 billion individual healthcare claims in the US every year. That costs an extraordinary amount of money. And that doesn't even begin to cover the cost to the providers who have to submit this paperwork, some of them dealing with hundreds of different insurance companies, some of them having to spend non-paid time to complete the paperwork to get the insurance company to pay the provider the money the provider is due. In the US, that consumes approximately 30% of all of the healthcare dollars that are paid in to our system. How does that compare? Well, it's twice as much as the nation that's in second place, whoever that is, and it's 3 times the average of industrial countries. Think about that. Of the healthcare dollars that we submit, we could save 20% if we reduce the billing paperwork. And if overnight the US went single payer and did nothing else, just changed how providers bill, we could save $600 million. That's a conservative figure. That is more than enough money to pay for all the unmet needs for people in the United States who don't get care. What has Oregon done about this? There are two factors at play here. One is in 2019, the Oregon legislature committed a task force, the Universal Healthcare Task Force, by passing Senate Bill 770. For 2 years, this task force looked at all of the ways that Oregon could provide better care to more people for less money. And they recommended that Oregon create a single payer system. That is, everyone in Oregon, instead of writing multiple checks to multiple insurance companies, multiple co-pays, multiple out-of-network payments, instead of employers making contracts, paying money to insurance companies, self-insuring, all of that money is collected into a single payer system, and every Oregonian participates. Your care is paid for. It's prepaid. Every provider is in the network. If a provider takes care of you, an Oregon provider takes care of you in Oregon, that provider will get paid. It's one piece of paper. The first step that the SB 770 task force recommended was that the legislature create a founding governance board. Now, when I get to the end during the question period, I will put a link in the chat so you can view that report. It's 250 pages. Don't panic. Most of that are references and appendices. There's about 60 pages of text, and even that gets easier because there's a 2-page executive summary. This recommendation from the task force for a founding governance board for a single payer system is the first factor at play. The second one is Oregon voters just inserted into the Oregon Constitution an obligation that the state of Oregon be responsible for saying that every Oregonian gets cost-effective, affordable care. There is no more cost-effective or affordable system for getting care to Oregonians than a state single-payer system. I would like, as your take-home message, well, your first take-home message is better care to more people for less money. Whenever anybody comes to you with a common sense idea for healthcare reform, you say better care to more people for less money. Which one are you missing? The second is contact your state legislators, your state representative, your state senator. And this part gets easy. Just write them a 3-sentence letter. 1, the Oregon healthcare system has failed me, or my family, or my business, or my clients, or my employees. 2, I want better care to more people for less money in Oregon. 3, I want you to make it happen. Sincerely, your voting constituent. And then P.S. When can we have coffee so you can tell me what you're going to do about it? You don't have to tell them that they're under now a constitutionally driven mandate to seek better care to more people for less money. And you don't have to tell them that the SB 770 committee told them how. They'll figure that out. And if they have any questions, just tell them you know this loudmouth anesthesiologist in Portland who would be happy to tell them exactly what they need to do. So I am going to put, if you'll let me, my eyes wander, I am going to put in the chat the link to the document. I will also put in my contact information. And then I will take questions. And I think the easiest way to take questions is the hand raising function, or seeing as how everybody's on one screen, you can just speak up and I'll probably figure out.
Okay, that's fine. I'm also glad a lot of times people will put their questions in chat and then I just look for them and read them. But however you like to handle that is just fine. I don't see any questions yet. I've prepared some advanced questions while people waited to create their own questions. Is there anyone else who would like to ask a question before I ask Dr. Metz a question?
This is Sylvia. I'll start with one question. If you have a single payer system in Oregon, then what happens when you travel outside of the state of Oregon and have a healthcare issue?
It's a great question. And in fact, it's even more complex than that. What if you are an Oregon resident and your work takes you across the country? Let's suppose you're a Teamster, or you're an iron worker, or you're in any of the trades that go across the country. The single payer system would have to have a private insurance aspect to it. So as soon as you, as an Oregonian, left Oregon and went to another provider, there would be a schedule of benefits and payments that that provider could look at. Every insurance is obligated to provide emergency care. So that this would not be new. It is an important detail. It's not insurmountable, but it would require work to make sure that the situation you're describing is answered, and we can do that.
Dr. Metz, the National Healthcare Plan has been discussed in the United States since post-World War II years, when a lot of other countries that do now have a form of national health insurance were establishing their systems. It's been discussed here since the Truman administration. I do know now that in Oregon, we do have Measure 111 that is embedded into the Constitution. But in addition to that, what do you think is different about this moment in moving forward a single payer plan in Oregon?
What makes this movement? Thank you. This moment special is the progress that we have made in discussions. You may remember that until there were discussions of the Affordable Care Act, you couldn't say single payer and get reelected. Bernie Sanders introduced that concept into the mainstream. We're now at the point where anyone who talks about healthcare reform has to start by saying why they favor or don't favor single payer. Our healthcare system will not reform itself. There's a great graph from actually Dr. Jennifer DeVoe, who's chair of family medicine at OHSU, in a paper she previously published that showed the projected rise in the next 15 years of family income in the United States. And superimposed on that, the rise in family healthcare costs for the next 15 years in the United States. Those lines cross in the foreseeable future, all of our family income will be dedicated to healthcare. It doesn't leave a lot for food, clothing, and shelter. There's a different kind of discussion at the national level, and there's clearly a different kind of discussion at the state level that things are not going to get better. We can either make big changes now, or we can make gargantuan changes after everything has exploded. So you will find your state representatives far more receptive to your letters and your inquiries than they have been before.
Okay, I see that Becky Powell has a couple of questions. She's mentioning that her physician is already drowning in paperwork and is underpaid. How can we keep the legislature from underfunding and over-monitoring healthcare?
That's a good question, because whenever anyone talks about healthcare costs, the first thing they say is, let's shaft the providers. Let's pay physicians less. Let's pay nurses less. Let's pay home healthcare aides less. Let's just pay everybody less. Well, that is an option, but when you pay people less, they go someplace else. So understaffing leads to low quality. That's a good phrase when you talk to your legislators. We don't need to underpay people in healthcare. Remember that most people in healthcare are not highly paid physicians like me. Most people in healthcare are licensed, they've got degrees, and they are working closer to minimum wage than they are to physicians. We already have understaffed hospitals for nurses. There are already too few home health care aides. I've wandered a little from the question. Remember that, well, Becky, you're correct that your physician is drowning in paperwork. As a matter of fact, about 10 to 15% of your physician's time is spent on paperwork. If there's just one insurance policy for every patient, one set of benefits for every patient your provider sees, the cost to that provider will go down. We don't have to underpay them. We just have to relieve them of the burden of paying the administrative cost of collecting the money they're due. That's a short, maybe almost inadequate answer to your question, Becky, and I want to acknowledge the import of it.
Dr. Metz?
Yes.
Yes, this is Ron Forrester. With respect to universal health care, as you stated, there is some level of care that we will guarantee everyone. And the problem I have is, how do you define that level of care? As you know, research is, in the medical fields continues, and new solutions come up all the time. Oftentimes new procedures, very expensive procedures, very expensive equipment is required, et cetera, et cetera. How do you define what is going to be covered? In other words, what's that base care and what is not going to be recovered? And I think, as an example, knee replacement, there was a time in our history where knee replacements weren't an option, and the treatment was wheelchairs, crutches, medicine, et cetera. Now, all of a sudden, somebody invented this new tool for a knee replacement, which I understand is fairly expensive. And maybe some people need 2 knee replacements, or maybe some people need 3 because this first one didn't work. How do you draw the line? How do you get the political resolve for drawing a line on what will be covered and what you have to pay for if you want more than that?
Ron, that's two critical questions in one. The SB 770 task force decided that the benefits available on the Public Employees Benefit Board is a good starting point because it's one of the most comprehensive sets of benefits in Oregon. So that would be the floor. We can pick out a pre-existing set of benefits that we know already works without going through it item by item and picking and choosing. But you've also implied something else. What's state of the art today might be outmoded tomorrow. And we don't want in the year 2040 to provide state of the art medicine as it was in 2022. Mm-hmm. Most countries have a program that reviews healthcare and results and makes recommendations that say, we've discovered based on fairly good literature and reports that this particular process is better than others. So we're going to now include it, this new process, in our benefits. They'll also discover a drug, a treatment doesn't work very well. We now have more information. So we are going to drop that and replace it with some other response. You ask a good question about how do we have an organic healthcare set of benefits that grows, that reflects the growing body of medical knowledge. That requires active revisions constantly. Most nations have that process in place. We don't have to invent a new one. There are models for it. It's an important concept. I'm not sure I answered your question completely, but I hope I came close.
Well, that was very good and I appreciate it. But it still didn't address the affordability issue. How do we go about a process? For example, you said that basic set of care benefits. How do we know that's affordable when everyone is included? Because right now, not everyone is. And so what's affordable to a subset of healthier people might not be affordable to the overall population that would benefit most from those benefits.
First, I follow you. First, in a single payer system, we pay into the system not according to how healthy or sick we are, but according to our ability to pay taxes, all prepaid. Ideally, the greater your ability to pay taxes, the more taxes you would pay into the system, so that the time you got sick, it didn't matter if you were rich or poor. Affordability. The patients who cost the healthcare system the most, that is, the patients who consume the most expensive healthcare with the worst results that make us look terrible compared to the rest of the country, are the patients who don't get healthcare until it's too late. That is how early access to healthcare reduces healthcare costs. If we have, I'll use your example, more total knee replacements, we will have fewer people off the workforce in wheelchairs dependent upon social services to eat. If we have more antihypertensive medications available to people as soon as hypertension is detected, we'll have fewer incapacitating strokes. If we have diabetic medication available early, immediately, we'll have fewer diabetic complications as I mentioned, fewer amputations. If we have more medication and treatment for coronary artery disease, we'll have less congestive heart failure patients who are no longer in the workforce. What we learn from other countries is that by providing much more primary care, much more preventative care, much more public health, it drives the cost of healthcare up a little bit, but we save enormously on intensive care, emergent care, tertiary care, care for the complications. It's called preventative maintenance in the automobile industry. If you change your oil regularly, you'll have fewer engine replacements. So the goal of a universal healthcare plan isn't to stop people from seeking care. The goal is to get everyone the health care they need as early as possible so we have fewer complex care patients to take care of.
Thank you very much. And
Doctor.
one just final clarification with respect to mental health care. I think our mental health care in this country is abysmal. Are these other countries that have universal health care treating mental health care universally as well?
I'd like to say yes, but it's variable. Access to mental health care services in the US is amongst the lowest in the industrialized nations. Oregon is the worst in the US. For access to mental health care, especially for children, Oregon always ranks 50. Sometimes someone else gets it wrong and we bob up to 49, but it's a real problem. It's an artificial division between mental health care and medical health care. It's a good way to reduce the cost of healthcare is just define it so it doesn't include anything above the neck. It doesn't include dental, doesn't include mental. That is an artificial deception. So please go back and as you review what I've said, anytime I say healthcare, yes, I mean access to mental health care as well.
Dr. Metz, I just want to make sure you're finish that answer and not interrupt you. Becky Powell did have another piece to her question, and then I want to make sure that other people who have questions can ask them. What if a person doesn't fit the income versus system costs model and cannot afford the insurance costs with single payer?
Single payer is not a multi-payer, multi-insurance system. It's a single state-run collection of funds. So everyone who pays taxes has bought into the system. There's no need to pay additional premiums, co-pays, deductibles, out-of-network costs. It's that simplicity that reduces the costs for providers and dramatically reduces the cost for patients.
I don't see any, Susan Cobb has her hand up. Susan, go ahead with your question.
I also see the golden palms of Juliana Cartwright and Margie Lynn. So let's go through the three of them.
Okay, let's go Susan, Juliana, and then Margie.
I'm sorry, I didn't see the other hands up myself. Relative to what you were just speaking about, that it's services provided to any who pay their taxes, basically. What about people who are not paying taxes? Like, I don't know, some like if we have visitors from Europe and then they have an emergency in Oregon.
I'm going to take two parts there. One is paying taxes is not a requirement to get health care in the single payer system.
Okay.
If you're in Oregon, if you are an Oregonian, however we want to define that, you get health care and your provider will be paid from the common fund. The second part, I believe, is we've got visitors from out of state and they need emergency care. Anyone who is not an Oregonian who seeks care in Oregon will receive a bill from the provider. Now, if that person has insurance in their home state or from abroad, they'll forward that bill to their insurer. If they don't have any insurance and they seek care in Oregon, emergency care, they will get care because there's a federal law that says if you need emergency care, you get the care first and you get the bill afterwards. That won't change. There are all sorts of variations on that, but that could go on a while. So I'm going to stop the answer there and I'll go to Juliana.
Julie Cartwright. And it looks like you're muted, Julie, if you're talking.
Shall we try Margie while Juliana?
Yeah, let's
sorts
try
that out?
Margie. That sounds good.
Got it. I got it. I'm sorry.
Oh, Julie's
hear me?
back.
Yes.
Yes, we can
Sorry.
hear you.
I was hitting the wrong unmute button, I guess. Thank you so much for this presentation. I'm a longtime supporter of single payer care. However, it seems to me we're going to have to make some huge shifts in what care we deliver as well as how we deliver it. And I believe that globally, other industrialized nations that have universal access are struggling with problems also, financial problems in their care systems, even though they are doing something along the lines of a single payer. And part of the reason for this is because of our demographics. We have an aging population, and we have an aging population that has chronic conditions and that also requires care that we don't label necessarily requiring licensed personnel. How do you address these types of issues in your plan?
Thank you, Julie. Every other industrialized nation with a universal health care plan has got problems. We could switch, just one for one, adopt the healthcare plan of any other nation, and we'd still have problems. We'd have different problems. We might have more problems. But no matter which country we switched with, we would receive better care to more people for less money. We will still have problems with people who don't get the care they need because they're geographically isolated, because they don't know where to go. In the United States, you can die from bad care anywhere in the world. The United States is the only industrialized country where you can die from no care because you can't afford it. And that's what single payer would remedy. Now, Julie, you also mentioned demographics. The healthcare challenges in the United States are not dramatically different from those of other countries. We don't have the most senior population. Japan has a much higher percentage of their patients who are over 65, over 90 for that matter. The United States has, get this, one of the lowest adult smoking rates in the world. Now, thanks to vaping, we're going to reverse that soon. but we have fewer smokers, adult smokers per capita than any industrialized country, except maybe Sweden. Alcohol, we consume about middle of the road in terms of gallons per year per person. Obesity, we still lead the world, but they're catching up with us. So the reason the United States spends more on healthcare than on other countries isn't because we have more healthcare problems. We spend more than other countries because we have the most inefficient method of getting money from patients to providers than any other place on earth. And that's what single payer would remedy. And I'm done. And Margie, you are up.
Thank you. I'm curious what your thoughts are about where the greatest obstacles and or resistance reside in terms of moving a plan like this forward. For instance, I'm thinking of insurance companies, that sort of thing.
There are several areas. First, just amongst us, meaning normal people, the challenge is we have to completely change an entire industry. Most Americans have no concept that things could be, that other countries are doing what we're doing, but doing it better. Most people can't imagine healthcare without employer-sponsored insurance. They have no model for it. Most people can't imagine insurance getting healthcare without copays or without changing or losing their insurance every time they change or lose a job. Part of this is simple education. But the really hard part is changing how money flows in the United States. Oregon spends about $40 billion a year in healthcare. If we have single payer, we'll get better care to more people for a little bit less money. But even if we save just $1 billion, which is what we estimate we could do while providing 100% coverage in the SB 770 plan, even if we do, when you change how $40 billion flows in Oregon, there are people who are going to get less money through their business and people who will get more money through their business. The people who have less money will object. The people who get more money will be grateful. But as you know, people who are upset shout louder than people who are grateful. Yes, this plan would almost eliminate the private health insurance industry in Oregon. Now, there are a couple modifying factors. One is there'll still be a call for additional benefits. There will still be people who have enough money who say, yeah, it's a great single payer plan, but I want more. I want private hospital rooms. I want experimental medications. I want unapproved treatments. And the insurance companies will cover that. Oregon is also unusual in that two of its largest healthcare insurers, Providence and Kaiser, are also part of a larger healthcare delivery plan. So Kaiser and Providence aren't going to go away. They'll, getting a little melodramatic here, they'll shut down their insurance wing and then move everybody over to the delivery wing because now everybody in Oregon is going to want healthcare and their delivery system is going to get paid. That's, again, it's short shrift to a complex question, but I'm going to stop there. And Karen, it looks like we have another question?
Right. Yeah, the question I had was about the super waiver that you mentioned in the advanced reading that you provided to us. You mentioned some of the steps that it would take in the Oregon legislature and the Oregon congressional delegation. So my question is, what is your view of the prospects of Congress granting Oregon a super waiver from the federal laws prohibiting states from pooling federal and private healthcare spending into a single payer fund?
This is a good point that we confronted in our SB 770 task force. Without intending to, there are a variety of federal laws that make it difficult, if not impossible, to pool all of the federal spending on healthcare into a single fund by a state. Imagine all the money that we get that's spent in Oregon on Medicare, on Medicaid, putting that into a single pool. Then imagine the same challenge of getting all of that money that we're spending on employers and employees are spending on insurance and getting that into the pool in the tax. To do this legally without violating federal law would require a complex set of waivers from existing programs. It's not even clear that that waivers exist to do what we want. What would be easier, by the way, that's true for any state. What would be easier to enable states to try single payer is for Congress to pass a law that says a state makes one application demonstrating it's a universal care plan. Nobody's going to lose benefits. Nobody on a federal program will be kicked off. You're not asking for more money than you're entitled to. If you meet all of these, we're going to issue a one, you got it waiver, and you don't have to apply for a dozen different ones. That's the super waiver legislation. States can't do that by themselves. What I would like to see is that we all pressure the state legislature to ask our congressional delegation to support a super waiver. Now, there is such legislation submitted in Congress. It's HR 3775, the State-Based Universal Healthcare Act of 2021. Two of Oregon's US representatives are already signatories, are already co-sponsors. We have 3 new members, and we have 1 member who hasn't yet signed. We should write all of them and say, Democrat or Republican, you and your family and your constituents are going to need healthcare in Oregon. And the best thing you can do to facilitate that is to let or create a waiver so Oregon can do that. I think I've consumed almost all the allotted time. So first, thank you all for listening. In the chat, you have my email. I would be happy to continue this discussion individually or answer any questions via email.
Okay. Thank you, Dr. Metz. I will provide that information also in our monthly newsletter that goes out. Thank you also for the comprehensive coverage and explanation of single payer, and also the public health information about how we as Americans are doing with health habits and also how we're doing with health outcomes. It really provides a great perspective about how we actually do when we spend more money than any other country in the world. So I appreciate your presentation. I appreciate your time. Thank you for spending this time with us today.
Thank you. Thanks for the great questions. Look forward to maybe seeing you all again.
Okay, thank you, Dr. Metz. And just so everyone knows, Our presentation next month will be about the OSU Cascades Innovation District, and we will be back at the Unitarian Fellowship. And that date, I believe, is January 5th. Yes, it's January 5th. So look forward to seeing you next month. I will save the chat with Dr. Metz's information with the link that he provided to a report and his email. And this presentation has been recorded. So it will